So thank you everyone for joining us again after a week off last week. This is the Mount Sinai Neurosurgery Medical Student Virtual Summer Course. It's our second year. I'm pleased to welcome probably one of our most extensively trained neurosurgeons from our department, if I could say that. Dr. Margetis completed his MD and PhD from top institutions in Greece before coming to the US and completing fellowships in both pediatric neurosurgery and complex spine surgery. He and I first worked together years ago at Cornell when I was a junior resident. I'm pleased to say he's been one of the most enjoyable people to work with that I've run into along my path. He practices general neurosurgery, trauma neurosurgery, and complex spine surgery. And he will be speaking to us today about spine surgery. And he'll tell you a little bit more about exactly what he'll be talking about and show you some really interesting operative videos. Just one other quick note, I'm going to promote many or all of you to panelists, so you have a chance to interact with him as you'd like. Feel free to decline being a panelist, but don't worry, we're not putting anyone on the spot. This is a stress-free environment. So take it away, Dr. Margetis.
Thank you, Dr. Morgensen. Thank you for your kind words. And hello, everybody. So today we will discuss about endoscopic spine surgery. I tried to keep the number of slides to a minimum, but they still end up being many. And we'll have several videos to see, which I think is more interesting than just looking at the text and photos of the presentation. I believe that most of you are panelists, so if you have any questions, please go ahead and ask me. Yeah, let's get started. I don't have any financial disclosures. So today we're gonna discuss about the endoscopic spine surgery. So what is the endoscope? The endoscope is basically this device. Can you see my pointer, my mouse pointer? I don't know if it is visible.
Yeah, we can.
Perfect. So this is the endoscope, where basically you can make a very small skin incision, just a few millimeters, and then you insert the endoscope inside the body, and then through some lumens that the endoscope has, you can visualize the tissue, and you can insert instruments and work through a very, very small incision and get the whole surgery done as minimally invasive as it can get. Actually, I was introduced in the endoscopic techniques when I was doing my pediatric fellowship and working with Dr. Morgensen, and we're using basically similar instruments to do intraventricular endoscopy in the brain. It's basically almost identical instruments, same principles. And it's a little bit different compared with endoscopy that we do for pituitary tumors, because in the intraventricular endoscopy, in the spine endoscopy, we have the constant irrigation of fluid, while in the pituitary endoscopy, we're working in the inside air. There is no like fluid irrigation. And we'll see a couple of videos to show you exactly what I mean by that. I'm sorry for minimizing, but these videos are very big, like 1.5 gigabytes each one of them. So I didn't want to have them inside the presentation. So this is basically an endoscopic video during the operation. This is what we're seeing through the endoscope, and all that is just from here to there is like probably 7 millimeters. So it's a very magnified view of the tissue. And actually this tissue here is the ligamentum flavum that we are penetrating right now. And then you can see over there is epidural fat. You can see here the epidural fat. And we insert the instruments further in, and we're dissecting. And there is constant irrigation, and that's why if there is any bleeding, the blood kind of obscures our field of view. And over here, you're seeing that we have identified the disc herniation, and we're removing that. And then another piece that we're removing, this is the annulus of the disc, and that's the herniated disc material that we removed. And here is the bleeding that I was telling you about. Look, I mean, this is a very, very tiny bleeding, but it can be very annoying when you're working under the endoscope, because it gets diffused into the cell in the irrigate, and it obscures the visualization. And here on the left, is the nerve, and we're lifting it up to make sure that there is no other disc fragment left behind. And this is the ligamentum flavum, and now we come out. So that was just a small demonstration of an endoscopic operation. Now let's go back to the presentation. So there are some advantages of using the endoscope and some also limitations. So you have a very nice visualization of the tissues as you saw. You can use basically all kinds of instruments that we use for open operations. There are some customized instruments that you can use. They're much small compared with the instruments that we use in open operations, but basically have all the, the usual instruments. Again, we're working under constant irrigation, and there's a liquid medium that we're working in, which has advantages because we're constantly irrigating. So there's very low risk for infection because we're constantly irrigating. But as you saw, there's even a tiny bleeder that can obscure our field of view. And there are some ways of how to overcome the bleeding and how to minimize how much it will affect your visualization. And another limitation is that you cannot really use two instruments simultaneously because you're working through a single incision. Now the equipment, these are three different types of endoscopes, but you see that there's a common principle that they all have a lumen where we insert the instruments, and it is this big lumen here. They have, this is the camera and the light in order to see, and these are two smaller lumens that they are for the irrigation of fluids. So basically, the saline is constantly irrigated through that lumen. It comes out through that. And here we insert instruments, and here's the camera and the illumination again. And these are some very common instruments that we use. The dilator is the first instrument that we put through the incision, and we advanced all the way down to the spine. And then over that dilator, we insert the cannula, which is this instrument here, which is basically just a piece of metal with a lumen. And then through that instrument, we insert the endoscope that has the camera, that has the lumens for the instruments that we saw before. We have cautery to get hemostasis and also to dissect the tissue. We have high-speed drills to remove bone. Here's the irrigation equipment. And when we're working, we're seeing everything through a big screen. That is usually on top of a tower that has all the other pieces of equipment that we need. All these pieces usually go on that tower, and the screen's on top of it. This is another view of how we do the endoscopic spine operations. You see here's the endoscope, and here they have started drilling the spine. And what kind of approaches can we use to approach the spine? For lumbar spine, the approaches, the endoscopic approaches are divided into two main categories. One is the interlaminar approach, where you go in through approximately the midline, and then you can access the central area here. You can access the lateral recess, the foramina, or the far lateral space. So just a quick note here. So this is an axial view of the lumbar spine. This is the vertebral body. This is the spinous process and the lamina. So the skin of the back will be around here. The abdomen will be around there. And here's the spinal canal. You can see a massive disc herniation there. So when we're dealing with lumbar stenosis, we usually divide the lumbar stenosis in four different zones: the central stenosis, lateral recess, foraminal, and far lateral. So basically, through interlaminar approach, you can access almost all of them, all of these zones. And so you can do a discectomy going straight in the lateral recess. You can go in and access both the ipsilateral, but also the contralateral lateral recess, and do like a thorough central decompression. And you can also have a more oblique trajectory and reach all the way to the foraminal and even far lateral zone on the opposite side. And over here in this image, I just want to show you something just to get a sense. So when we're doing a laminectomy, we're removing the part of the bone that is inside the purple dotted lines. So we remove all that bone. When we're doing a laminotomy to remove a disc herniation through an open or a minimal invasive approach through a tube, we remove the green shaded area. But when we're using an endoscope, the endoscope has this size, and most of the times we're able to fit it in between the bones, so we don't really need to remove that much bone, because the endoscope is very, very thin, and we can fit it in between the bone, and we just need to remove the ligamentum flavum and get access into the spinal canal. And I want to show you here something, a very basic maneuver that we do when we're doing endoscopic discectomies. And we call it the rotate to retract maneuver. So when we're doing, I mean, this is an axial view. You can see the disc herniation, and you can see here the thecal sac with the nerve roots. You can see here the extended nerve root. And when we're doing an open operation, we use an instrument and we retract the thecal sac and the nerve roots medially. We recognize the disc herniation, and then we're able to work. But with endoscope, because we're only having one instrument, we need to come up with a different way to retract the nerves in order to be able to access the pathology. So the way we do this is we advance this. So you can advance, sorry about that, you can advance the endoscope with the deep beveled end laterally and advanced all the way to the annulus. And once you have the deep end of the instrument in contact with the annulus, you rotate it this way, and that way you are able to retract the thecal sac, and you are looking directly into the pathology. You can also, if you want to, you can retract it even more in traditional way to access more of the pathology. That technique was proposed by Rutten in 2013, and it's a very helpful maneuver. And actually, I have a video to show it. And actually, now we're going to see a couple more videos to get a better sense of what we do and what we see through the endoscope. So here is the ligamentum flavum. Here is the opening in the ligamentum flavum. You can see the neural structures there. And this is the bipolar cautery that we will start dissecting. So here's the thecal sac, and we're inserting that instrument laterally to the thecal sac to dissect. And we're very carefully dissecting because the dura is very, very thin, and you can very easily, get a dural tear, very, very careful. And now what we're gonna do is we're advancing the deep end of the beveled end of the cannula against the annulus of the disc. You can see here the nerves. And now we're gonna rotate, you'll see. Again, we're dissecting here a little bit more. You see here's the deep end of the cannula, and here are the neural structures that we need to protect. And at about this point, we start to rotate very carefully. You see here now we rotated that, and we have retracted the neural structures medially, and we are protecting them. And now the pathology, which is the herniated disc, you see how the herniated disc looks like cotton. So that's very typical, for herniated disc material. And then here we proceed with the discectomy with this instrument, which is like a small pituitary roture. And again, we check here to make sure that everything is good with the nerve. So this pink structure is the nerve, okay, that we need to protect, and we need to work around it, or basically get in front of it to access the pathology. Okay. Now, let's see a couple more videos. All right, so here we have a case of a 56-year-old lady that she had left leg pain. She had tried conservative treatment. Usually they do epidural steroid injections. Nothing was helping her. And the MRI saw that she had a small disc herniation on the left side. It was small, but it was pinching, the nerve. It was correlated with her symptoms. So we offered her surgery, and let's see how we do the surgery. Again, here is the cannula of the endoscope, and the way we docked it right under the lamina. And here is some soft tissue over the ligamentum flavum. And we're resecting that tissue. Here's the ligamentum flavum that actually means yellow ligament because it is, as you can see, it is yellow. And we're very carefully and slowly resecting the ligamentum flavum. And you can see here that we start seeing fast. So that's the epidural space, that's the spinal canal. So we're gonna open up a little bit more. And here we're advancing the cannula of the endoscope. Here's the epidural fat. And you can see that the nerve as it, that pinky structure is part of the nerve. Again, here is towards the head, the medial is this way. And we have here the deep end of the cannula. And I think, again, we're gonna try to do the rotation maneuver to retract the nerves medially so that we are able to visualize the pathology, which is the disc herniation. You see these tiny epidural veins, when we're doing open approach, I mean, we don't really see them that well, even under the microscope, you don't really get that magnified view as you can get with the endoscope. And here we're using the cautery to just dissect around to recognize the pathology. And here's the rotational maneuver that we're doing. And now the pathology is right in front of us. You can see the pathology, which is actually was a semi-calcified disc. When the disc is calcified, is much harder, in palpation, but it's also more difficult to remove because we cannot really grab it with the traditional rotures that we use. So we have to use other methods, and in this case, I think we use the drill. Let's see. So you see here, we're using the instruments, and there is like a soft component that we can remove, but there's also like a calcified component. You see that's calcified. And here, I mean, you're only looking, but surgery is like, I would say 50% palpation. We're using your hands and we're using our sense of palpation to do many things. And here we're using the drill to drill, and remove that calcified disc herniation. Because as you saw, we couldn't remove it with the usual instruments that we use for this purpose. So calcified disc is like bone, okay? So we remove that, and now you see the nerve. There's nothing there pushing on the nerve because all that area was occupied by the calcified disc herniation before applying pressure on that nerve that was the cause of your pain. But now, as you can see here, that calcified disc is gone. Okay. Let's see a couple more. So this is another case where we did just laminotomy, and 51-year-old man, and he had, you can see here, lateral recessed stenosis. You can see here, how tight that space is, and also here. So what we're gonna do is we're gonna do a laminotomy to decompress that lateral recess that you saw on the MRI. So again, here we're removing part of the ligamentum flavum. And so, yeah, just to orient ourselves, let me pause here. Oops. So here's the superior articulate process. See, here's the ligamentum flavum. This way is towards the head. Here's the fasten joint, and here's a superior articulate process. So that way is lateral, that way is medial. Okay, so bone, flavum, head, legs are this way. So over here, we're using that instrument. We're trying to elevate the flavum, the ligament from the bone, just to recognize the bone a little bit better. You can see here the bony edge. You can see the flavum that looks yellowish. And when we're doing this operation, it's very important to stay in that interface between the ligamentum flavum and the bone, because that way we know we're not too far lateral and we know we're not too far medial. And over here is the tip of the superior articulate process. So when we're dealing with lateral stenosis, that tip of the superior articulate process is the bone that is causing all the stenosis. And again, here, superior articulate process, flavum. Here, this slit-like space is actually the fastened joint, okay? And this is the inferior articulate process. Over here, we have thinned the bone, and we're using that instrument to break it. And again, a little bit more drilling. So you see that everything became very wide. It's because the drill is cutting the bone, and the fluid, I mean, the sealant gets filled with little bony pieces. And here we're using the keratoconus. You probably have seen that in open cases. And over here we have reached over the tip of the superior articulate process. Actually the tip was there, and it was removed, and that's a sign that we have achieved adequate decompression. Here is the opposite side that we're going to be working. Oh, sorry, actually still the same side, still the right side. And we're removing some more of the ligamentum flavum, because sometimes the flavum can be very thickened, and it can contribute to the stenosis. And now we come out, we're happy with the degree of decompression, and we remove the endoscope. And now going to go to the left side. Again, we have docked the endoscope, and there is some soft tissue, some very thin layer of muscle that we're going to clean in order to recognize the bony structures. And here there is bone, here is the ligamentum flavum. Here's the inferior articulate process of basically the part of the fastened joint, and we're drilling on it. And as we go deeper, we are trying to dissect the flavum of the bone. I know probably, on the screen, everything might look the same, everything looks like yellowish or whitish, but on the screen of the endoscope thing, there's a better, contrast between the colors. And also, as I told you, surgery is 50% palpation here. I'm not relying only on the visualization, but I use that probe to palpate around and feel what is bone and what is flavum, what is ligament. And here is an articulating drill bit that it articulates here, and allows us to reach over corners. You see how it articulates, and that's I have found to be very, very useful for this type of cases. And we're moving more of the bone, and now we're moving part of the ligament. And you see that over here we went into the canal. Okay. Now we're using the keratoconus. And on this side, we selected to remove all the ligament to see the nerves. On the opposite side, we didn't do that because on the preoperative MRI, the ligament was not appearing to be very thick. On this side, it appeared to be a little bit thicker, so that's why we decided to remove part of the ligament, and the nerve was right deep inside there. So, but let me show you one more video. And I mean, things don't go always as as planned. Complications do happen, and let's see the complication now. Over here, we're using again the roture to start cutting, the flavum, and we're inside the spinal canal, epidural fat there, and look what happens here. Oops, that's a tiny nerve rootlet. So basically, the instrument inadvertently in addition to the ligament, engage the dura, and then engage also a very tiny nerve root and cause a small dural tear. And over here, we're trying to expose the dural tear and visualize. So I think it was that area over here, the dural tear. You can see it here, this small defect. So here's dura, and here is the opening, the dura that was created by the instrument that engaged the dura. It looks big, but actually this is just like 2-3 millimeters, maximum. It's not much bigger than the opening that is happening when we're inserting like a tuchi needle for a lumbar drainage. And the way we selected to repair that, it was basically take a piece of Surgicel, which is this foamy material, and just plug it in. And the advantage of the endoscopy technique is that because we're working through this very, very small incision, and there's a very small corridor that we use to get down to the spine, there is very little chance to have CSF leak through the wound. So over here, although we did not primarily repair the dura by placing a stitch, we just use that to plug it in. And actually the patient woke up fine without any issues. We kept her overnight for observation, but she had zero symptoms, no headaches, no nothing. And that's an advantage of the endoscopic techniques. Now, before we go to the second type of approach for lumbar endoscopic operation, which is a transforaminal approach, I would like to tell you a few things about the Camping's triangle, because it's a very, very important anatomical structure that is not usually, we're not taught about it in medical school, in as much detail as I think that it requires. So basically, the Camping's triangle is this triangular area between the exiting nerve root and the bony structures of the spine. And it was described by Camping. And so here's the triangle and various images. So here's an anatomical view of the Camping's triangle, and here's the thecal sac, here's the exiting nerve root, here's the pedicle. So the head will be this way, feet will be this way, and here's lateral. And so the Camping's triangle is basically this area here where we can access the disc space between the exiting nerve root, between the thecal sac, and between the bony structures of the spine. And in normal patients, it can be a pretty sizable, space. But actually, in patients who have degenerative spine disease and they have hypertrophy of the ligament of flavum and of the osseous structures, this Camping's triangle ends up being like a very, very small slit-like space. So here's an anatomical specimen and of the spine. Here are the fasten joints. So the head will be towards the left, feet will be towards the right, abdomen will be down here. And this here is the exiting nerve root. And the Camping's triangle is this slit-like space. And why is it so narrow? Because we have significant hypertrophy of the fasten joint. So this is an area that it gives us access to into the disc space. And as I said, in normal individuals, it's a pretty sizable space. But when there is pathology, it can be a very tight space. A few more things now I will discuss about the intervertebral foramen, because that's where we're working in through the transforaminal approach. You can see here the nerve root as it goes through the intervertebral foramen, and there are some tiny ligaments. They have names. To be honest, although I'm looking at that area very, very frequently, the endoscope, I haven't been able to recognize all these ligaments. We see some structures that look at ligaments, but I haven't been able to pinpoint that this is, for example, the inferior versus the mid. But anyway, that was a nice anatomical study. A few more things that we need to remember, that the nerves that they're moving, they're not really remain, let's say, they slide in and out through the foramen as we move our legs, and when we bend our knees, or when we're raising our straight leg up, the nerve gets stretched and slides out of the spine. So if there is something pinching the nerve, then the nerve gets too much stretch because it cannot normally slide in and out, and then there's a lot of pain. There are also many veins in the foramen, and over here I wanted to show you something that we learn about in anatomy, but we don't really get to see that often, not even in open operations. So as the nerve exits the foramen, it gives the ventral ramus, which is like the main part of the nerve that goes down to the lumbar plexus and then goes down to our legs. But they also give the dorsal ramus, which is this tiny nerve here that innervates the facial joints, innervates the muscles and the skin of the back. And we don't usually see that nerve when we're doing open approaches, but we get to see it when we're doing endoscopic approaches. And now we get to the transforaminal approach, where we approach the spine not through the midline as we saw before, but through a very oblique trajectory, and we go into basically very close to the Campanese triangle. And again, here we have the 4 zones that we talked about, and an axial view of the spine. And you can see that this patient here has a significant foraminal, lateral recess, foraminal, and also far lateral disc herniation that we selected to approach that pathology through the transforaminal approach. And over here is a little bit more technical slide. Here's the exiting nerve root, and here are 3 different locations on where to dock the endoscope when you're doing these operations. This is the Campanese triangle, the blue dot. The green dot is to dock it right on the superior articulate process, and the yellow dot is to dock it at the junction of the transverse process in the facial joint. My preference is to go for the yellow dot, but as in every surgery, everybody needs to be familiar with all variations, because each patient is different, and one patient might be a better candidate to, let's say, put it in the blue dot, another might be a better candidate to put in the green dot, etc. So let me go back. And okay, now let's see a video of the transforaminal approach. So 69-year-old lady that you can see here on the sagittal view. You can see here the axial view, significant foraminal disc herniation, and you can also see it here on the sagittal view. This is the disc herniation, and here's a normal nerve that is surrounded by fat, which is the white area, that the hyper intense lighter area that you see here. And here's the nerve, and as you can see, there is a little bit of fat here, probably a little bit there, but the nerve is very badly pinched from the disc herniation. And she had left anterior thigh pain, which correlates with the compression of this L3 nerve root. And we offered her surgery because she had failed conservative treatment. And let's see what we did. So here we have docked the instrument, and now we are using the cautery to dissect around and to get some hemostasis. And you see that there is like a structure that comes into our field of view that kind of bifurcates in 2 branches. I don't know if you can see it here. There's this pinky structure that bifurcates here. So actually, that's the dorsal ramus of the nerve that we discussed before. Here's the transverse process, the L4 pedicle, and we're going to resect that dorsal ramus. And somebody say, "Oh, what are we doing? I mean, are we resecting like a nerve?" And that's actually a nerve that mediates the low back pain, and it is the nerve that the pain doctors they target when they're doing the blocks for low back pain, and also when they're doing the radiofrequency ablation of the medial branch to treat a low back pain. That's the nerve that they're burning. So it's a nerve that we very commonly, let's say, resect or ablate in clinical practice to treat low back pain. And that tiny nerve was in our way to treat the pathology, and we felt that we need to resect, otherwise the manipulation of the instrument will have caused significant damage to the nerve, and probably they will have caused like neuropathic pain. So that's why we selected to resect it. And probably, by resecting, we would probably help the patient with her back pain as well. And here is the disc herniation, and we're buzzing on it to to see it a little bit better and to shrink it a little bit. And we start now resecting the disc herniation. And here you can see this is the extinct nerve root. When we're done with our decompression, you can see the extinct nerve root is this pink structure there. And again, this cotton-like material that actually the herniated disc. And here we are trying to control this tiny oozing that, although it was minimal, but again, it can, it can interfere with our visualization. That's why we want to control this very, very tiny bleeder. And again, here we continue with our discectomy. And here we're using the drill because part of that disc herniation was calcified. So we're using the drill to make the resection a little bit easier. Right, now that's the x-ray of where we were. There are several technical details, but probably it's out of the scope of this presentation. That's why the video is a little bit long. I had showed to our residents, and we're going through some technical details about how to do that procedure. Okay. Right. So, why are we using, the endoscope to do these operations? Is there any evidence? And actually, there is, and it's not like anything new. I mean, this evidence has been around since 2008, but there is like a learning curve for somebody to, start doing, these endoscopic cases. So that's probably why, this technique hasn't really become more popular. Although, as you can see here, there was evidence from 2008, where they were showing that the endoscope technique had significant advantages in regards to the back pain and fewer complications and overall less invasive. And that has been shown also that is very, very effective. It's a valid technique and very effective for recurrent disc herniation, as you can see from this group. And the endoscope techniques are much more popular in Europe, as you can see from these publications, and they're also very, very popular in Asia, like China. Korea is a big power in endoscopic techniques. In United States, I mean, we have started, I mean, there are a couple of people who use it, and they're really pushing the envelope, but it's not as popular as in these other, locations that I told you about. So for lateral recess stenosis, which was, the third video that we saw, you can see here the evidence that, again, It's probably associated with less complications and less invasive. You can do bilateral decompression. And there is this theory that probably the best operations to apply the endoscopy techniques are not probably the very simple ones like discectomy, because if a patient has a disc herniation, I mean, I can do the discectomy using a tube, and the patient will still go home, within 2-3 hours, the same as if I do it with an endoscope. But probably and also, if we're dealing with a very big operation where we have to do like osteotomies, deformity correction, I mean, you cannot really do that with the endoscope. Probably, the area, I mean, the complexity level that, the endoscopy techniques are so most benefit is, this middle zone, not very simple, not very complicated. And has been shown in one of the publications by Christoph, but the Hofstadter from Seattle. And let's go now to the fusion, because you can also do a lumbar fusion with the endoscope. And we have done several cases here. And the main advantage that it can take less time, and it carries the potential of doing the operation under sedation, under monitor anesthesia. So it has been shown that you can do these operations without general anesthesia, which is a huge thing if you're able to do these operations without putting the patient under general anesthesia. Probably it is associated with less epidural scarring. Again, you can do the operation through a very small scar incision, minimal blood loss, minimal need for postoperative opioids. And again, the way you approach the disc space is through the Campan's triangle. Again, you can see the red line is the extended nerve route that you should not injure at any cost. Here's the fastened joint, in the purple dots, and this is basically your corridor to get access into the disc in order to do the interbody fusion. There are some specialized instruments. One company came up first with specialized instruments where you can insert these instruments through the endoscope, and you can work. Because this is articulated curette, so basically it articulates and you can remove the disc with that instrument. And there's the articulating drill bit that we saw that is also very useful for this type of technique. And also it's the expandable cage technology that really enabled us to do this type of operations, where you can see here the cage fitted through this very narrow cannula. And once you're inside the disc space, you expand it, and it expands into the height that you want it. So let's see now a video of endoscopic fusion. So this lady had, as you can see here, a spondylolisthesis. So you can see here, this is a line along the posterior vertebral body wall. And you can see here, there's like a step off. So she had a dynamic spondylolisthesis and she had significant back pain. And that was the reason we offered her surgery. And what I would like to show you is over here, where right inside the disc space, we have removed most of the disc. And you can see again, this cotton-like material is basically the nucleus pulposus. And over here, we're using the cautery to shrink that disc material. And now we're using the drill bit, and we're drilling off the cartilage from the end plate. We want to expose the bone, because when we're doing interbody fusion, we want to expose the bone and you can see here's the bone that is a little bit bleeding there. And that's what we want to see, a little bit of bleeding bone. You can see here, very nicely prepared. And here's the opposite side, bleeding bone. There's still some disc there, but it's not an issue. I have removed the majority of the disc. And here we're working on the fastened joint. We're basically disrupting the fastened joint. We remove the soft tissue with a cautery. And this slit-like space, the fastened joint, and then we're going to use the drill to disrupt it to induce fusion through the fastened joint. And this is the construct at the end. And you can see here is the disc space that we prepared, and we put the disc, we put the expandable cage, and we have expanded it, and we also put some bone graft over there. So when you're doing a fusion, here we want to fuse that bone to that bone. So we made sure that we have exposed here the bone, we have exposed the bone there, and we packed that space with bone graft. So that bone graft will get incorporated into the patient's own bone, it will form a bony bridge between this vertebra and this vertebra, and then we'll achieve the fusion of these two bones. And we also disrupted the fastened joints that you saw in the back, hoping that there will also be a bony fusion through the fastened joints. And again, where is the evidence for the advantage of the lumbar endoscopic fusion? So the evidence is still relatively weak, but there is definitely, there is definitely something out there that shows that it carries significant potential. And it's less invasive, less cost of low back pain, less blood loss, faster recovery. But the main issue is that the indications are still relatively limited. You cannot apply this technique to all the patients who need a lumbar fusion. And again, this is a publication where they showed that they can do an either body fusion. It was a little bit modified technique compared with what we saw before, but same principle. And they were able to do it without general anesthesia, which is again a big deal. Having like such a major surgery without general anesthesia. And so let's see a few techniques for the cervical spine. So here's an axial view of the cervical spine. You can see the spinal cord, the disc. So one application of the endoscopic spine surgery, the cervical spine, is to go through the back, do a posterior approach, do a small laminotomy from foraminotomy, and do a discectomy through a posterior approach, which is very, very reasonable. And it's a good indication for endoscopic spine surgery. Some people have pushed the envelope and they have used the endoscope to do percutaneous discectomies going from the front. I don't really feel comfortable trying something like that. And I find it too risky, percutaneously passing that instrument between, the carotid artery, the esophagus. And then I don't really feel comfortable, doing that operation, but there are some people, especially in Europe, that they commonly do that technique for soft disc herniation of the cervical spine. And there are some other people that they have really pushed the envelope, and you can see here a massive central disc herniation, where basically they approached it from through an oblique trajectory. You can see here on the endoscope, they went in, they drilled the bone, they were able to access the pathology. I find this technique, too risky. I mean, I give credit to the surgeons who do it, because it's a very, very, very dangerous technique. Because when you're doing that technique, you have, the spinal cord over here, you have the exiting nerve roots here and there, you have the vertebral artery in front. So passing the endoscope through this very narrow corridor to get to the pathology, I don't know, I find it a little bit, too risky, and I'm not really willing to try such a technique. At least until there is significant evidence that shows that it is safe. But I just want to show you how some surgeons, they're really pushing the envelope, and the potential that this technique carries, I think is great. I believe that it'll become much more popular in the United States, as it is in Korea, in China, in Central Europe, as I told you before. And I believe that's a technique that it's much more difficult to learn it if you're attending. I've seen, this some of my colleagues, trying to pick up that technique as attendings, and it was a little bit more difficult for them. But I have shown the technique to residents, and it was very easy for them to pick it up. And I don't know if it is the different mentality that the residents have. They're a little bit more bold in adopting or learning a new technique. I don't know what was the factor, but if you get the opportunity to learn that technique during your residency, definitely grab that opportunity and try to learn it, because I believe that, as I said, there is great potential with this endoscopic spine surgery technique for the future. We have 10 minutes, and at this point, I think we can take any questions. So there is a question actually in the chat. What are the more likely complications found in endoscopic procedures as contrasted with the open approach? That's a very good, very good question. So the answer is that it depends on where you are at your learning curve. When I started doing this technique, I realized that I was kind of overestimating the amount of decompression that I was doing. You know, I thought that I had removed more bone, more ligamentum flavum, and than I had removed, because when I had to go to like an MRI for a different reason, you know, for adjacent level pathology or something like that, I was kind of underwhelmed with the amount of decompression that I did. So I would say that when you start doing this technique, probably the greatest risk is to undertreat the patient, to not decompress enough, because you're looking through the endoscope. You know, you're looking in a very magnified view, and you think you have removed a ton of bone when you have removed, you know, a very small amount of bone. So that requires a little bit of experience, and if you walk next to somebody who is a little bit more experienced, you know, I think that this complication can be prevented. Later on, you know, you can have, you know, the usual complication. You can have a dural tear, as you saw, but especially for dural tears, I think that the endoscopic spine technique is much more forgiving, because you're walking through a very narrow corridor, as I said, and when you remove the endoscope, the soft tissue collapses and it closes that corridor, so the CSF does not have a pathway to leak through the wound. So it can happen, but it is more forgiving, as I said. Another great question from John. What are the thoughts of combined use of augmented reality endoscopic spine surgery? So actually, you know, that's I think the future. You know, the main limitation of that I have found, you know, the endoscopic spine surgery is that you have a very limited view of the bone, so it's very easy to get disoriented. You know, you're looking at the bone and you don't know exactly what part of the bone you're looking at. So if you're able to combine, you know, the endoscopic spine surgery with an augmented reality, that will be, I think, a major breakthrough. You know, you'll be able to you know, take away the major limitation of the endoscopy, and you'll be able to do the surgery much faster and with much higher confidence that you're at the correct level and you're resecting the bone that you want to resect. I think it's part of the future. The screws not for endoscopic fusion surgery. The screws are not dropped endoscopically. They are dropped in the traditional percutaneous technique. And actually, you know, I can do like the interbody fusion through a 7mm incision that actually, you know, when it heals, it's very difficult to find it. You know, it doesn't look like an incision. It looks like a very tiny spot of skin discoloration. While, you know, for the percutaneous screws, you still have to do a little bit bigger incisions, and they definitely look like incisions. You know, I believe that eventually, you know, as technology evolves, probably there will be a way to drop a screw endoscopically. But whoever, you know, thinks of a good way to do it, I think that he should patent that idea, because it will be, again, a major breakthrough for spine surgery. So do patients get to choose which endoscopic approach they're more comfortable with? No, that's something that it's a surgeon's decision. It has to do with the location, basically, of the pathology. If the pathology is a little bit more centrally located, then it's probably better to go through either laminar approach, versus if the pathology is more the foramen or far lateral, then it's probably better to go through a transforaminal approach. Also, it has to do with the level that you're working. If you're working at the L4-5, L5-S1, it's probably easier to go through the interlaminar approach, because it's a little bit more difficult to get the transforaminal approach, because you'll be hitting the iliac crest. You cannot get like an oblique trajectory because the iliac crest will be there. Pediatric populations. So, you know, that's another excellent question. So, you know, thankfully, you know, in pediatric patients, we don't get to see degenerative spine disease. We get to see other types of spine pathologies. And we haven't, I'm not aware of anybody who has really expanded that technique in pediatric populations. You know, there are also, you know, in addition to the endoscopes that we saw, there are some other, you know, endoscopes that they're much thinner. So I had in mind, you know, some indications, for example, to do like cord detethering, you know, if it is like a focal cord tethering. So there are some potential indications, but I'm not aware of anybody who has tried it. At least I'm not aware of any publications about it. Any other questions? Okay. Again, I think that the take-home message is that it is a technique that is still, is still growing. The indications are still, expanding. I believe that it carries, significant potential, and I think that in the future it will be much more common. Probably in combination with newer technologies like the augmented reality that was mentioned. Also, I believe that the endoscopes will also become smaller in the future. These endoscopes, the endoscopes that we use nowadays, the technology has been the same for like almost 40, 50 years. And they're using like traditional optics. So we haven't really used like modern cameras, modern, let's say, LED lights to, we're still relying on traditional, lighting methods. So there is a lot of room for innovation in the field. And I think Clementine has raised a hand.
Hi, Dr. Margetis. Yes, I just wanted to ask, thank you for allowing me to speak. It was a really insightful presentation. I mean, we've seen endoscopic surgery, especially for neurosurgery, becoming such a big deal over the past few years. And, we can predict that it's only going to get, a bigger deal. But I was just curious, from a training and learning perspective, what is the learning curve like for residents to really start getting comfortable with using the endoscope? I can imagine how, even, scrubbing for your first surgery as a resident neurosurgeon can be daunting enough, when you're doing open cranies. But with endoscopy, do you find that it seems easier for them to learn, or more difficult, or is it something that they usually have to do more studying or more reading about, or do they just, get it after a few procedures? Thank you.
Yeah, great question. So, when I started, doing this procedure, I think that I had not selected, the right patients, and I had significant difficulty, using the technique. And in retrospect, I had done a very bad, selection. I started with some difficult cases, basically. Okay, and I had the opportunity to discuss with some people, from Germany that they had more experience, and they told me that, probably when you start doing this technique, you should probably start with an L5-S1 lateral disc herniation, like a very simple type of pathology. And that way you'll become a little bit more familiar with the technique, and then you can build from there for the interlaminar approach. For the transforaminal approach, you can probably, a good first, surgery to do is like a foraminal disc herniation, L3-4, which is easily to access, and you go in and you can be done with the operation literally like in 5 minutes. You can be done with the operation. So yeah, I think it has to do with a good patient selection. I think it will be useful at some point to do like a cadaveric course where you'll get to, let's say, play around, and see all the anatomy that you don't want to see in a real case. See where the nerve is, see how far you have to go further into to reach the thecal sac. So I think that it's a combination of good patient selection that has to be done by the attending. So if you scrub in a complex case, you probably gonna get the maximum educational benefit. You might not be able to understand everything that the attending will be doing. So yeah, I think that start with easy cases, cadaveric training, and it's important to get some hands-on experience, because it's a different skill set. You cannot really use the skill set that you have doing open cases for the endoscope. The way you're holding the endoscope actually is causing a lot of hand fatigue when you start doing the first cases. You have to get used to hold the endoscope, and yeah. And I think that if you get the opportunity to learn that technique during your residency, it's a big advantage. It's very, as I said before, it's much easier for a resident to pick up the technique than an attending. I've seen some very, very competent, very, very, very good spine surgeons that had difficulty starting the technique as attending. Well, I saw the technique in a PGY-4 resident. Right away he was able to pick up and to do part of the case. Very good. So it's 8:30. If there are no other questions, I think we can stop here. Thank you very much for attending this event. If you have any suggestions, you can email Dr. Morgenstern. I hope you found it useful, and I try not to keep it very simple. Probably, I use a lot of technical terms, but I think it's important to at least get to hear these terms and get to hear, how we think, what we're looking for, and as you continue your training, all these things will make sense. Even if we said something that you probably did not fully understand during your training, you'll get to understand that. Again, thank you again, and have a good night.
Thank you. Have a good night.